Sonia. Raises a lot of questions, which I'm sure hopefully we'll come to at some point today, and perhaps also in the consensus discussion we have. So the next speaker in this session is Ara Kassarjian, who's from Madrid, not from the USA. He's originally from the USA, has an American accent, but he speaks Spanish.
Not from the US originally.
I know you. Yeah. Well, okay. We're not going to your life history, but you speak a lot of languages really, really well. You're going to talk about pathology and relationship with imaging findings.
Excellent. I want to thank the organizers for the invitation. This has been a fantastic conference yesterday and so far this morning, and I'm really looking forward to seeing the rest of the conference. I hope to contribute a little bit to it myself. I have a kind of a broad title here because they gave me a little bit of time to talk about a lot of things. I'm going to focus a little bit on some of what was covered earlier. First of all, I want to thank two of my very good friends and colleagues, Adam Zoga from Philadelphia and Fernando Iduarte from Pamplona, who contributed to some of this knowledge that I'm going to present today. And the objectives for me today are to talk about symphyseal and perisymphyseal causes of groin pain, and then a couple of non-symphyseal causes, specifically Iliopsoas and subspine impingement, which is related to the rectus femoris, as we'll see, and because those are two of the other very common causes of groin pain that were mentioned yesterday. I'm not going to discuss FAI. We're going to have a whole session on that later. I'm not going to specifically talk about muscle injuries or stress fractures or snapping psoas because I think we're going to have some ultrasound talks on those as well. So let's start with symphyseal and perisymphyseal causes. These are the four main causes I want to talk about today, and we'll go through them one at a time. And I think that we had an excellent talk about the anatomy of the rectus abdominis, and so I'm not going to review that here, but we'll see it again in a second. So let's talk about the injuries at this junction between the rectus abdominis and the adductor aponeurosis. And these are important because this is one of the settings where surgery is being considered. And I think it's important to start thinking about that as we're going to have some talks about surgeons coming up later today and tomorrow. We saw some of this earlier, and this is supposedly one of the more common injuries to this site. And with the MRI, the classic finding that we see is a secondary cleft sign, as you see here on a coronal and axial fat-suppressed images. These are stir images. And what we see, as was just pointed out, and there's a pointer. This is a primary cleft, and a secondary cleft is usually an oblique, high-signal fluid type of signal line that goes typically to the side of symptoms and undercuts the attachment and the origin of the adductors. On the axial images, you can see that this is closely related to the adductor longus, which is here, and you can see the fluid-filled cleft coming anteriorly and inferiorly. Sometimes it goes posterior as well, and that's going to be what we're going to talk about. The superior cleft sign, which was also just mentioned, was recently described by Murphy, who's part of Steve Eustace's group in Dublin. And this is, instead of being oblique and inferior, this is more horizontal that comes out of the primary cleft. And this is the images from their article where you can see that, again, we see the primary cleft within the symphysis, and the superior cleft actually goes nearly horizontal, and it's usually more anterior and superior to the secondary cleft. And here's another case where they can be subtle, but if you look closely and you have high-resolution images, you can see how there's a small superior cleft going towards the right side of the patient in this case. And to compare the two, I think if you start looking at these, you can start differentiating that one is actually oblique and inferior, and maybe posterior inferior, and the other one is more horizontal and usually more anterior. Originally, we thought the secondary cleft sign was, a tear of the common adductors at their origin. Now with the superior cleft, maybe the superior cleft is more related to the adductor longus, and the secondary cleft is more related to involvement of the short adductors, such as the brevis. That's not clear. This is relatively new material, and I think it needs to be looked at more closely. One thing I want to stress, though, is it's always important to look at those sagittal images, as was also mentioned regarding MRI techniques, because occasionally you will only find these small tears on the sagittal images. I think if you have good axial and coronal images, you can usually pick them up, as well as some of those oblique coronal images that are often used. But I always like to review the sagittal images as well. Many protocols don't include a sagittal in your routine pelvis. So if you're doing routine pelvis and growing pain, you always should have some sagittal images going through the symphysis pubis as well. Let's look at midline plate injuries. And now we get into this confusing terminology, and there is no real standardized terminology here. And I think that's something we need to work on. So when we talk about midline plate injuries, we're talking about involvement of this anterior inferior arcuate ligament. It's this plate. Some people call this whole thing the prepubic aponeurotic complex because we really don't know what we should call it, what it's exactly made up of. But we do know that it's sitting there along that anterior and anterior inferior portion of the pubis, and it's probably very important in terms of stability of the symphysis pubis itself. This has been said to be a less common injury. Is it because it's actually less common, or we just haven't been looking for it or noticing it? That's not clear. And these tend to be more severe injuries because as you involve this midline structure, as we saw in the biomechanical study yesterday, if you actually sever the symphysis pubis, then you have instability. If you sever the ligaments, you have instability. And this is one of the stronger ligamentous structures at this symphysis. And so involvement of this may actually contribute to more symphyseal instability. This is still not proven scientifically, but I think that's the best thinking right now. And because of that, I think these are the ones that people like to operate on more, or at least tend to operate on more. And it's been said that if you have this, it's more important. It's very important to do bilateral repairs, even if they have symptoms only on one side, because there's a risk of recurrence. Again, the data is scant, but it seems to be heading that way. And you can see in these images, I apologize for the quality of the upper image. On the lower image, you can see this is an anterior inferior arcuate ligament, and it's a very anterior structure. And on a patient here, you can see that there's actually disruption of that, and you have this fluid cleft. So it's actually like that horizontal line that I showed you. It's that superior cleft, but it's crossing the midline. I think it's important to appreciate this is actually involving that midline component. These are our images from Adam Zoga's group and Dr. Meyer's group, I think, here as well. And you can see that you can have small midline cleft injuries, such as this one here, or these huge injuries that essentially just separate all these structures from the symphysis pubis. And as we said, this may play a role in instability of the symphysis pubis, which can be picked up on radiographs if you have the flamingo views with weight bearing on one side and the other to show that instability of the symphysis pubis. Now let's go to osteitis pubis. I'm in total agreement with the lecture yesterday that what really is osteitis pubis. I don't know. I think it's just some entity that I don't really understand myself. I do think it's probably a joint-based process, and I say that because when I see changes on both sides of the joint, even if they're asymmetric, I tend to think that it's a joint-based process. That is what we see in other joints, so why not here? Typically, we see edema on both sides of the joint, as we see on these coronal and axial stir images. It may be asymmetric, and that's okay. The irregularities along the margin of the joint, I think, may be normal in younger patients, as was mentioned, but it is a sign that's been described with osteitis pubis as well. I think our role is to not miss other lesions that are often associated with edema around the symphysis pubis. So if you see perisymphyseal edema, you shouldn't just say, oh, it's osteitis pubis, next case. I think we really have to look and make sure we're not missing other lesions, such as those aponeurotic tears that I showed you. Here's a case, 2 different patients where you can see edema on both sides of the symphysis pubis. So this is theoretically osteitis pubis, but if you look more closely, you see this midline plate injury. And I think that's very important to make that distinction. Other lesions that I see missed oftentimes are these stress fractures. And you have to be careful. This is a patient that's almost mature, so you still have part of the apophysis here in the cartilage, but then you actually have a stress fracture adjacent to that. So this is not the normal growth. This is actually a stress fracture, and that can be confusing depending on the age of the patient. And then the adductor tendon itself, we see tendinopathy quite frequently, actually. I know there isn't much published data on this, but in our practice where we see a lot of soccer players and tennis players, we see a lot of tendinopathy, and it's often asymptomatic. We probably should go and review that more closely. In this case, you can see that the common, the anterior longus tendon, which is part of the common adductor tendon probably, is a bit larger on the left and then the right. It's a subtle case. And then we see the adductor tears, and these are not hard to see. The tendon is completely separated from the entire perisymphyseal complex, and you can see a fluid-filled gap on this axial T2 weighted image, and this is the fluid-filled gap. I think what we need to really look at closely in these cases is go back and look at the sagittal images to decide whether this is strictly a tendon abnormality or is this now actually involving that entire complex, that midline plate, that upon neurosis and extending up and involving part of the lower rectus abdominis muscles and its sheath and the joint capsule. Those may be two different entities. I think it's a continuum, but they may have consequences regarding treatment. So let's leave the symphysis behind a little bit, and we're going to look at perisymphyseal causes. I'm just going to talk about two of them. I want to talk, and because I don't think either of these have been mentioned yet today, yesterday, and I think one was briefly mentioned today. We're going to talk about iliopsoas impingement and subspine impingement. So iliopsoas impingement, for those aren't familiar with it, it's when the iliopsoas tracks along the anterior aspect of the hip, typically during hip extension, and you get bursitis and tendinopathy of the iliopsoas tendon. You also, because of that friction along the anterior capsule, you can get lesions of the anterior labrum. And these present with anterior hip and groin pain after prolonged sitting. Occasionally, they can report a snapping hip. And I'm not going to go into snapping hip because I think it's a better ultrasound diagnosis. And these are the patients that have no other signs or anatomical signs of femoral having their impingement. So they don't have the cam lesions, they don't have any pincer lesions. And what we look for in these is on the sagittal and oblique axial fat-suppressed proton density images, you can see how this iliopsoas tendon is very closely associated with the anterior capsule and the anterior labrum. This is the labrum here, you have the capsule there. Here's the iliopsoas tendon. It's actually the two components you can see here that were mentioned earlier. Oftentimes we see three. You can see edema around that tendon. If we mag up, you can actually see that there's increased signal in the labrums. There's an actual labral tear, but it's getting crushed and degenerated. And that's what they see at arthroscopy as well. They often see a frayed labrum, a degenerated labrum, as opposed to those classic labral tears that you see in other types of impingement. And the treatment for this, I think this is a relatively new concept. Usually it's a conservative treatment, whether it's anesthetic or steroid injections, either into the iliopsoas bursa or into the hip joint, because as we know, they often communicate. And sometimes it's not clear if the symptoms are from the labral fraying, from the friction of the capsule, or from the bursitis or the tendinopathy itself. In refractory cases, they'll do a iliopsoas tenotomy. They usually do this arthroscopically. They go in, they do a capsulotomy. You can see the iliopsoas tendon right there, as we saw on the previous image. It's right in front of the capsule. And they actually do a tenotomy of just the tendon of this iliopsoas. And so you still have that large muscular component that still attaches. You're not actually sacrificing the function of the iliopsoas. And finally, subspine impingement. This is related to the rectus femoris, typically to the direct head of the rectus femoris, occasionally to the indirect head. And it's often related to athletes that had an injury to the rectus femoris while they were still growing. So they had an apophyseal injury, they had a either minor or major avulsion injury, and then it healed, maybe after further injuries, and remodeled, and you end up with this osseous protuberance at the origin of the rectus femoris. And this is one of the causes of extra-articular hip impingement. So when you go through the impingement test, they have the same signs as if you had a cam impingement, or very similar signs at least. However, it's an extra-articular pathology as opposed to a primary intra-articular pathology. And just to review that anatomy, in these sagittal images, you can see this is looking at the anterior-inferior iliac spine here. And as we go more laterally, you can see this is the direct head of the rectus femoris. As we go more laterally, you can see there's another component here that is actually attaching on the lateral margin of the acetabulum. These are two heads of the rectus femoris that join a bit further down. And as you have injuries of these, you can, in the younger children, you have apophyseal avulsions, as we see in this sagittal fat-suppressed proton density image. This is the anterior-inferior iliac spine. This is a big chunk of bone that has been pulled off. The direct head is somewhere in here. In this case, the indirect heads remained intact. In other cases, you have actually avulsion of both tendons, and then you can either just have tendons avulsion and ossification, or you have apophyseal avulsion and ossification. The end result is that you have this osseous protuberance. You have extra bone sitting there. It's almost like this hook. They can be quite large. And you can see this on these axial CT images and these three-dimensional reconstructions where you have this big hook of bone anteriorly. And you can imagine as you put this hip into adduction, flexion, and internal rotation, this may contact the proximal femur, oftentimes along the femoral neck as opposed to the actual head-neck junction, but it depends on the actual configuration of this ossification. This can be seen with MRI, but I think it's much better seen with CT scans, and the surgeons like this better for actual operative planning. is often treated arthroscopically. Some people prefer to do it open, but the typical thing to do is arthroscopically if they know where to go and they can plan. If they do also have associated intra-articular pathology, that will be treated at the same time. So to conclude, I think we've seen that there are lots of causes of groin pain. I only mentioned a few of them. I think it's very important to keep in mind that close relationship between the abdominals, the adductors, the midline plate. I think it's a very complex anatomy. The terminology is confusing for me and I think for a lot of people. And the actual treatment is probably confusing as well to some. And then non-symphyseal causes, I just talked about a couple of them. It's good to keep these in mind. But the bottom line is, and I think we heard this a lot yesterday, and we're going to hear this over and over and over again, the key is to correlate the imaging with the clinical and the clinical imaging. Sometimes we see so many things on MRI, especially in athletes, and a lot of them have absolutely no clinical relevance. So I think it's very important to keep that in mind. Thank you.